Good morning, dear students. Today we are going to learn about sacroiliac joint. Sacroiliac joint, it is a joint between the sacrum and the ilium bones of the pelvis. And these sacrum and ilium, they are connected by strong ligaments. In humans, the sacrum supports the spine. The sacrum, it supports the vertebral column, and it is supported in turn by an ilium on each side. So the function of sacrum is to support the vertebral column, and in turn it is supported by on either side by the ilium. The joint is strong, supporting the entire weight of the upper body. Now we have two sacroiliac joints. These are a pair of plain synovial joints. Roll number 151. What are the other examples for the plain synovial joints in the body? You have to answer. Through which the body weight is transmitted from trunk to the lower extremities. So these are a pair of plain synovial joints through which the weight of the body is transmitted from the trunk to the lower extremities. Now, despite of the synovial nature, the mobility of the joints is sacrificed to maintain the stability. So they maintain the stability, the sacroiliac joints, though they are synovial nature. The stability, which is manifested by the interlocking arrangement of the articular surfaces of the sacrum and the ilium, by the shape of the bones and by the strong ligaments. Now let us discuss about bones forming the joint. Bones forming the joints are the auricular surface of the sacrum and ilium. So we can make out here the articular surface of the sacrum and the articular surface of the ilium. The articular surface of the sacrum is covered by hyaline cartilage, that you have to remember. The articular surface of the sacrum, it is covered by hyaline cartilage, and that of the ilium with fibrocartilage. In early part of the life, both surfaces are flat, but with maturity, irregular elevations and depressions appear on the articular surfaces, so that we can make out when you see the sacrum, and if you see the articular surface of the sacrum, you see the irregular articular surface having various elevations and depressions, and also the iliac articular surface also will have various elevations and depressions. This ensures joint stability by interlocking arrangements. Coming to the ligaments of the sacroiliac joint, consist of capsular ligament, ventral, interosseous and dorsal sacroiliac ligaments. So these are the ligaments of the sacroiliac joint: fibrous capsule, ventral, interosseous and dorsal sacroiliac ligaments. The sacrospinous and sacrotuberous ligaments are the accessory ligaments of the sacroiliac joint. The capsular ligament forms a thin envelope and is attached to the margins of the articular surfaces. You can see here in this diagram, we can make out the margins of the articular surfaces give attachment to the capsular ligament. The ventral sacroiliac ligament, you can make out here, this is anterior sacroiliac ligament. It covers the anterior surface of the joint and forms rather weak band. Some of the fibers are attached to the preauricular sulcus. preauricular sulcus. So that is about the capsular ligament and ventral sacroiliac ligament. Coming to the interosseous sacroiliac ligament, it is one of the strongest ligament of the body. So we can make out here the interosseous sacroiliac ligament. Now this ligament, it lies immediately dorsal to the joint. This is the posterior view of the ilium and the sacrum. So it lies immediately dorsal to the joint and consists of deep and superficial parts. It consists of deep part and a superficial part. The deep part is composed of cranial and caudal bands. We can make out the bands over here. The cranial and caudal bands, which extends between the depression of the lateral mass of the sacrum and the iliac tuberosity. The superficial part, it covers the deep part. This is the superficial part of the interosseous sacroiliac ligament. It covers the deep part which fills up the irregularities between the sacrum and ilium. Some of its cranial fibers form short posterior sacroiliac ligament. So we can make out here. So some of the fibers of the superficial part of the interosseous sacroiliac ligament, they form short posterior sacroiliac ligaments. Now next, the dorsal sacroiliac ligament. So we can see here, this is dorsal sacroiliac ligament. It lies superficial to the interosseous ligaments and extends obliquely from the transverse tubercle of the upper 3 or 4 sacral segments. From the upper 3 or 4 sacral segments to the posterior superior iliac spine. So we can see here, it extends from the 3 or 4 sacral segments up to the posterior superior iliac spine. So this point is known as the posterior superior iliac spine. Obviously this is anterior superior iliac spine. Some fibers form long posterior sacroiliac ligaments. So some of the fibers, they form long posterior sacroiliac ligaments. Coming to the anterior relations, nerve supply and the movements of the sacroiliac joint. Anterior relations are the lumbosacral trunk, the ventral rami of the first sacral nerve, and the superior gluteal artery intervenes between them. Nerve supply, ventral surface of the joint is supplied by superior gluteal nerve, which is derived from L4, L5, S1, and dorsal surface by the branches from S1 and S2. In the joint lesion, pain is sometimes felt in the posterior part of the iliac crest and along the iliac and line of sciatic nerve in the upper part of the back and the medial side of the thigh. In the lesions of the sacroiliac joint. Now what are the movements at this sacroiliac joint? Some rotatory movements take place around the transverse axis, which lies about 5 to 10 centimeters below the sacral promontory. So this is sacral promontory. So just 5 to 10 centimeters below the sacral promontory, there is a movement around the transverse axis. This movement is associated with slight translation, since the nature of the articular surface permits such movement. The complex rotation is observed during flexion and extension of the trunk. So you know what is flexion and extension of the trunk, and more so while rising from recumbent position, or you can say from supine position to standing position, or from sitting position to standing position. The rotatory movement occurs in both sexes, and during pregnancy the range is increased. About 5 millimeters to 6 millimeters of forward rotation of the sacral promontory is considered to be the normal range during weight transmission.
We will briefly review the characteristics and biomechanics of the SI joint. The SI joint is the connection between the spine and the pelvis. The SI joint is a true diarthrodial joint. The articular surfaces are ear-shaped, containing irregular ridges and depressions. Its concave sacral surface is covered with thick hyaline cartilage, and its convex iliac surface lined with thin fibrocartilage. Biomechanically, the SI joint's movement is induced by motion occurring at other locations in the body. This movement is very small, with less than 4 degrees of rotation and less than 1.6 millimeters of translation. While the SI joint is vulnerable to shear during rotation or translation, compression of the joint allows it to resist shear. Those structures that produce joint compression include the interosseous ligaments and the joint capsule, including strong posterior ligaments protecting the network of adjacent nerves. In addition, a number of muscles contract and co-contract to provide stabilization for the SI joint during movement.
The sacroiliac joint, as a joint, just like any other joint in the body, is subject to both internal and external forces and can be affected by a variety of processes or problems. One of those problems could be an inflammatory arthritis or autoimmune problem, such as rheumatoid arthritis or ankylosing spondylitis. The joint can become degenerative because of trauma, either acute trauma, such as a motor vehicle accident or a fall, or chronic repetitive trauma. In some series, up to 50% of the patients with sacroiliac joint dysfunction or pain had reported a precipitating traumatic event. The joint could also be subjected to increased stress as a result of being next to a lumbar fusion. We call that adjacent segment degeneration. Another common problem with the sacroiliac joint is that it becomes hypermobile or dysfunctional. This would typically occur in a middle-aged female. Females are somewhat more ligamentously lax than males, and it commonly occurs in females who've had multiple pregnancies. The clinical literature would represent that between 15 and 25% of patients presenting with low back pain have the sacroiliac joint as the source of their pain.